Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone and welcome to one of our new series in which we are going to discuss the latest RCPI guidelines, inshallah. And as you can see, we are going to start with recurrent miscarriage and recurrent pregnancy loss. This guideline, guys, is very important for the exam. It appeared recently in the latest one also, March 2025. So try to pay attention with us. And if you want to get notifications for our latest videos or summaries or activities, please subscribe to the channel, of course, and join our WhatsApp group or Telegram group. Okay, let's start directly. Why this guideline is important? Because those cases of recurrent pregnancy loss are very special cases. They are not like any other lady that can have a normal antenatal care. So it's very important to know who is going to take the title of recurrent pregnancy loss. Which lady is going to be titled as a case of RPL? So we need to know the definition. The definition we have here is very important because it's very unique to the RCPI. It's different from the RCOJ in some cases. And the reason why we need to know this is because when you figure out that this lady is RPL, you are going to refer her to early pregnancy service or recurrent pregnancy loss clinic, more specifically. So this could be exam answer for your exam question. This lady with a specific criteria or a lady who is presenting to early pregnancy service with the same criteria, what are we going to do with her? The correct answer is refer her to the RPL clinic. So who are they? Who are those ladies? Let's see the proposed referral criteria. This is why I told you it's very important to know them. The criteria is going to be any woman with 3 or more consecutive pregnancy loss. Consecutive pregnancy losses means one pregnancy loss after the other, not sporadic. And this is why I told you it's important to know whether you are dealing with a normal lady that's going to need a normal antenatal care because she's having sporadic miscarriages, or someone with 1 or more second trimester pregnancy losses. A lady with 1 or more second trimester pregnancy losses is RPL. A lady who is over 35 with 2 pregnancy losses only, 2 or more, of course, is also RPL. So this is very important for part 3, by the way. You have to detect the risk factors. Any woman with history of pregnancy loss, and you know that it's because of a placental disorder, like preeclampsia, like antiphospholipid syndrome, maybe she's having PCO, or she's having a chronic medical disorder like diabetes, like thyroid dysfunction, or a problem with prolactin. All those ladies are going to need referral to the RPL clinic. And not only this is something unique to the RCPI, there's also something very unique to the RCPI, which is the initiation of investigation and evaluation for women or couples with recurrent miscarriage after 2 consecutive miscarriages only. You shall initiate the pathway. And this pathway is composed of some investigations and some empirical treatment, and of course, the treatment of any underlying medical condition. So let's see what kind of investigation that we can do for those ladies. First of all, we have recommended investigations and unrecommended investigation. Theoretically speaking, also this could be exam question. They could bring you SBA telling you which of the following is not recommended. So you need to know which investigation is not recommended. I'm going to start with the recommended one, of course. The first thing is performing the antiphospholipid screening at least 6 weeks following pregnancy loss. And then we are going to repeat the test 12 weeks later if the first one is positive. This is very important in your exam also, because choices could be very specific, like when you should do it and when you should repeat it. Not only this, patients should be advised not to get pregnant before the release of the results of the second blood sample. Okay, because this could affect the interpretation. And I think this point here could be very important for part 3 during counseling. The second test is going to be the thyroid function test. So we are going to do the TSH and the TPO antibodies, followed by the T4 screening. Rubella IgG, and which is very unique also to RCPI. They are very concerned about the rubella serology. And then, forget about this now, I'm going to come again to it. We need to do cytogenic analysis for the product of conception. Then first, after doing it, we are going secondly for parental karyotyping. So first you have to do cytogenic analysis for the product of conception. For all ladies? No, not for all ladies. We are going to do it in general from the third and subsequent miscarriages, or if the lady is less than 35 years with no prior live births and she is in the second miscarriage now, you should do cytogenic analysis for this miscarriage. And again, this is unique for the RCPI. So we have two cases: someone who is less than 35 with no prior live births, we can do from the second miscarriage, or in general, we can do after the third miscarriage. Okay? In case something went wrong with the cytogenic analysis, and by the way, the preferred test for the cytogenic analysis is the microarray. It's not mentioned here in this guideline. You should know it for general knowledge. Microarray is the best investigation. It weighs between the benefits of several techniques, and also it does not have the same expense like the whole genome sequencing or next generation sequencing. Anyway, after doing this and we reveal that there is translocation or there is something wrong, we can do the parental karyotyping. And this is why you are going to find that it can be considered based on individual assessment. So not all ladies are going to have parental karyotyping, only those with abnormal cytogenic analysis. Okay, next we have the uterine anatomy. I'm trying to go through the routine testing, okay? And then I'm going to discuss with you the case-by-case investigations. So uterine anatomy is very important, of course. Why? Because maybe she's having a congenital abnormality and this is why she is miscarrying, right? Maybe she's having cervical insufficiency and this is why she's having second trimester miscarriage. So assessing the uterine and cervical anatomy is very important. We shall do it at least by the 2D TVS, more specifically by 3D ultrasound, which is the gold standard. And if you want to do hysterosalpingography, this is plus or minus. If you want to do the MRI, this is adjuvant, but at least 2D. The gold standard is 3D, plus or minus other imaging, okay? If you discovered a Mullerian uterine malformation, whether it was problem with junction or a separation, either or, you need further investigation to delineate any renal tract abnormalities, right? The best for detection of renal tract abnormalities would be the MRI of the urinary tract, of course. Other investigations that is not recommended for all women, it's case by case, would be parental karyotyping, as we said, screening for hereditary thrombophilia, you are only going to offer it for those with family history of hereditary thrombophilia or history of VTE. If there is relevant menstrual or fertility history, you can order the day 2 to 5 hormonal profile. And this is already well known if the case is subfertile. So yeah, she's not only having miscarriages, but also she is subfertile. So okay, I'm going to order this. But they are not routinely recommended for all women. Okay, so if we want to revise quickly for the routine investigation, this is going to be antiphospholipid syndrome, rubella IgG, screening for genetic factors, because of course chromosomal abnormality are the most common cause of sporadic and consecutive miscarriages, both of them. Okay, and think with me, uterine abnormalities, excellent. Those are the routine one. And thyroid dysfunction, excellent. Okay, the recommended investigation also, but this is usually done for cases with any case of miscarriage, any case, histopathological examination of pregnancy tissue. Can you figure why? This is safety point, of course. Why? Because this could be molar pregnancy. This miscarried baby or pregnancy could be associated with a molar pregnancy, or itself, it is a molar pregnancy. So routine histopathological examination of pregnancy tissue is recommended. And if there is any available histopathological result from previous miscarriage, guys of part 3, pay attention with me, take care of this, please. You have to look at the report because there are some lesions that can carry a recurrence risk, like chronic histiocytic enterovillocytis. There is histiocytic deposition between the villi, or there is fibrinoid deposition between or around the villi, which is called massive perivellus fibrinoid deposition. Those two conditions have recurrence risk, so you need to be aware of them. Okay, when shall we go for investigation for male factors? In couples with recurrent miscarriage or those who are having also a subfertility history. We can do a sperm analysis if you are suspecting from the history of the male that he is having some risk factors that can affect the sperm health or the sperm quality. And this is very important point because guess what? One of the unrecommended testing for recurrent miscarriage is routine sperm DNA fragmentation screening. This is unrecommended. Okay, so this is very important. I'm just trying to get whether smoking, paternal age, alcohol consumption, if any chronic medication, if he is having heavy exercise pattern, taking steroids, he's obese, those can affect mainly the motility and the teratogenicity. But severe male factors should be investigated separately as case of subfertility, not miscarriage. And this is why further on in this guideline, you are going to find out that we don't know for sure if doing routine sperm analysis for all cases could be beneficial. So again, it's not a routine, it's going to be only for those high-risk cases. Just like infectious screening, only done for those have signs and symptoms of vaginal infection or uterine infection, right? Also, those who are having luteal phase insufficiency, this is subfertility. Testing for PCO, this is also a case of subfertility. So we are not going to do it for all ladies, as you can see, in the context of searching for the cause of miscarriage. This is very important. Okay, just knowing this, we need to know the possible treatments for those women. If the lady is yield now to have antiphospholipid syndrome. By the two tests, 12 weeks apart, both of them are positive. We need to give her aspirin and low molecular weight heparin. Exam question: when shall we start the aspirin and when shall we start the low molecular weight heparin? Aspirin preconceptionally, low molecular weight heparin as soon as the pregnancy test is positive. What if the woman turned out to be hypothyroid? Overt hypothyroidism. Overt hypothyroidism means high TSH, low T3 and T4. She shall start treatment with levothyroxine right away, with the referral to endocrinologist, of course. But if the lady turned out to be subclinical hypothyroidism, which means she's only having high TSH with normal T3 and T4, or she's having positive TPO, what shall I do now? Actually, we are not going to give treatment to those who are having TSH between 4 to 10. Those are called mild to moderate subclinical hypothyroidism, and treatment of those ladies are still controversial with low quality evidence. So you are only going to give treatment for those with TSH above 10, not 4 to 10. Remember this, it's not mentioned in details in this guideline, but it's mentioned elsewhere. We also need to do something for them. We are not going to leave them alone, of course. They are still at risk for miscarriage. So what shall we do? We shall check the TSH levels in early gestation, 7 to 9 weeks. Okay, further follow-up is mentioned in the thyroid guideline, but at least I want to make sure that pregnancy is not going to convert this young lady from subclinical hypothyroidism to a real case of hypothyroidism. So if you detected that she is hypothyroid in the very early pregnancy, you are going to give her levothyroxine. Again, having positive antibodies alone, and the patient is euthyroid. Euthyroid means normal T3 and T4. You shall not give her levothyroxine outside a clinical trial. So it's not a routine treatment. What shall we do with genetic abnormalities? Offer genetic counseling. If the patient was discovered to have hyperprolactinemia, give bromocraptin. What if the patient figure out to have no apparent obvious lesion cause for recurrent miscarriage? There is no reason. This is what we call unexplained recurrent miscarriage. Those ladies usually are at increased risk of placental dysfunction, but yet we don't know for sure what's going on. And as you know, or maybe you haven't read the RCOG guideline before, either the Irish guideline or the British guideline, both of them do not recommend doing immunological testing for the uterus. It's not recommended yet, okay? So empirically, we can give something, and this is very unique to the Irish College again. We shall give low-dose aspirin, we shall give high-dose folic acid, and progesterone vaginally, not orally, okay? Vaginally. So, if a woman is having unexplained recurrent miscarriage, we shall give her those three, and those three are the correct exam answer. There is nothing, someone is above the other. Okay, so I think it appeared like twice or three times in the previous recalls. All of them are important. At least aspirin and high dose folic acid is a must. And if the patient is having 3 or more consecutive miscarriages, you shall give her empiric progesterone administration. Again, this is totally different from the RCOG, because the RCOG is not recommending giving any treatment for unexplained recurrent miscarriages. We have other unrecommended treatments. You can go through them. I don't want to conflict you by saying them out loud. Anything that we haven't mentioned is unrecommended. Okay, whether it was immunotherapies or HCG or something like empirically for PCO, this is not going to help with miscarriage. Some of those treatments could be good for a case of subfertility, but not for miscarriages. Okay, so don't conflict this with that. Now we are coming to the very end of our discussion, and this could be very important for those candidates for post 3. Some sort of treatments are still very controversial and only done for clinical trials. Or let's say we are not really sure of their effectiveness because of the lack of high quality evidence, which is, shall we remove the uterine septum or not? If we have a uterine septum, shall we remove it or not to improve the live birth rate? Actually, in the context of recurrent miscarriages, we shall not remove the uterine septum. Whether you are going to do a hysteroscopic metroplasty, or you are going to do a metroplasty for a bicorbial uterus or double cervix, all of those are not recommended yet because of the lack of sufficient evidence or high quality evidence. Again, this could be different from the metroplasty for the sake of subfertility. It's totally different because you know that NICE guideline is going to advocate the removal of a polyp at least or submucous fibroid, right? For the sake of subfertility. But for the sake of recurrent miscarriages, there is insufficient evidence supporting this. So it's not recommended. And this could be very important for a case in part 3 where your patient is having a uterine septum or having a congenital abnormality related to Mullerian dysfunction or a mucous fibroid or a polyp. Okay, this is going to be very important in case discussion. So finally, you are going to find a common pathway for anyone. Refer to the early pregnancy assessment, like here, for example. If this young lady is having pain and bleeding, she could be miscarrying, she could be ectopic, she could be a normal pregnancy. I have no idea. So I need to make sure that she is hemodynamically stable first. And then I'm going to triage her as emergency case. So I'm going to refer her to the emergency department or not. And according to the gestation and according to the presence of any suspicious symptoms for ectopic pregnancy, we shall manage, of course. The only important point here is urgency of referral. Urgency of referral is very important for the written exam and, of course, for part 3. So if the woman is having symptoms or signs suggestive of ectopic, immediate referral. If not, you can counsel her out of hours of service, or you can counsel her in early pregnancy unit anytime in the morning, okay? According to what? According to the urgency or according to the heaviness of bleeding, let's say, or her psychological state. Maybe she's very depressed and she is crying heavily and so on. So you shall manage her according to her case, but urgency is always there for those who are having signs and symptoms of ectopic pregnancy. Okay, guys? And at last, you are going to find this very informative algorithm for investigations for recurrent miscarriage. You are going to find everything we have discussed together. And of course, the points of uniqueness for RCPI, the age that we have talked about before, when to perform the cytogenetics, and the routine testing, as you find here. The anti-nuclear antibodies is not routine testing. but it can be done after 2 consecutive miscarriages. Thrombophilia, as we said before, it can be inherited or acquired, and we mentioned before that the inherited thrombophilia is not a routine. We can consider hemoglobin A1C if the patient is high risk for diabetes, of course, and if she's having a previous history of gestational diabetes, this would be the most important risk factors. And that's it. I hope we have done a good job summarizing this beautiful guideline. It's not difficult. You just need to make sure of the question and take care of the tricks that can come in the question, especially if they are asking about points that differ the RCPI from the RCOG. Thank you so much for following us. Don't forget to press like and subscribe. See you next time, inshallah.